Hello, my name is Konstantinos Donas. I am vascular surgeon in Münster, Germany. I am here in Spain, in Barcelona, attending at the CIRSE meeting 2019, and I'm really glad to introduce you my colleagues, Dr. Taneva, a vascular surgeon from Madrid, Professor Frank Vermassen, University of Ghent, Belgium.
Hello.
Hello. We are here and we will speak about the critical issues on chimney endografting, a round table of Radcliffe Vascular. And I would like to start the discussion with you, Frank. Nowadays, we have new evidence about the chimney endovascular technique in the treatment of complex aortic pathologies. We have new evidence. We have the new guidelines of the European Society of Vascular Surgery, highlighting the utility of this technique as an alternative approach. What is your current practice? Based on your experience, can you tell us in a summary form good indications for Chimney-EVAR?
Well, Konstantinos, nice to be here. It's obvious that the neck is one of the major criteria for successful EVAR procedure. And especially the quality of the neck, which includes length, diameter, conicity, different properties. And it's in our practice, chimney has found its place actually in some of these necks where, on one hand, EVAR is not really a solution, a durable solution. And on the other hand, FEVAR might not really be indicated. I think chimney certainly has its place, let's say, in those necks below 10 millimeter to 15 millimeter, where EVAR is not implanted according to the instructions for use. And on the other hand, it can indeed, let's say, diminish the need for FEVAR. We cannot forget that FEVAR, for instance, is not possible in those patients that need to be treated emergently. Emergent treatment includes bailout situations. That's obvious. I think there is an obvious indication for chimneys in bailout situations. Also in those patients where, for instance, because of the diameter of the aneurysms, we do not want to wait for custom-made fenestrated or branched endoprosthesis, and where those that are more readily available do not suit very well because it's only in a small percentage that these can be used. So that's the second big group. A third group, in my opinion, are also those patients which, well, there is some doubt because of their age, because of some comorbidities, whether it's really cost-effective to implant a very expensive prosthesis and which we can help very well with a cheaper solution. Yes. I do not want to say by telling this that Ch-EVAR is the poor guy's solution or alternative for FEVAR, but in this world where, you know, some economic arguments might come into play, this might be
Thank you.
a solution.
Indeed, very nice. You highlighted the good indications for chimneys. Well, in general, the philosophy of this approach is that we are using off-the-shelf devices. It means devices which are available in the stock of the hospital. And I would like to ask you, Dr. Taneva, speaking about Chimney-EVAR, do you have an overview of the current recommendations, which devices, based on the literature, based on your practice and experience from your hospital, seems to have nice conformability, minimizing the issues like gutters, persistent type 1A endoleaks?
Thank you very much, Professor Donas, for having us here and for your invitation. It's nice to be at this round table with Radcliffe. Yes, exactly. This is the Achilles topic, I think, and Achilles heel of the chimney technique. Which devices should we use and what's the recommendation? Because we have seen from literature that we have some different and diverse results for the topic. From the Pericles registry, for example, we have some good midterm patency and very nice results. But then, of course, there are some suboptimal results with different used devices. That's why we went a bit further and we did some in vitro testings, which we are currently still ongoing and doing. We constructed a very sophisticated in vitro model following the CTA of a treated Ch-EVAR patient. And we conducted several device combinations to see which devices go better with which endograft. So out of all the tested devices, it seems like the best performance up to now is Advanta and Endurant. And this is actually the recommendation followed up after Protagoras study as well. That's why device combination is very important for the performance of the Chimney technique. And it's not the same to use one device or another, and we can't expect the same good results.
Thank you. Yes, one very important point, Frank, is, as Dr. Taneva highlighted, the device combinations. One other critical issue is the degree of oversizing. We have to keep in mind performing Chimney means that we will deploy parallel and outside of the main abdominal device additional abridging device, a covered stent. So we have to have enough material to wrap up the chimney graft. And I think this is very important to plan and size correctly. So from your practice, how important is the oversizing for this technique, and what is your recommendation in this field?
Well, as you said, it's very important indeed. You know, at first sight one could think because of the additional material that you would need a smaller device, which is not true, because you make the curves around the chimneys. So therefore this oversizing is an important element in avoiding the creation of gutters, which are kind of the Achilles heel of the chimney technique. So depending on the number of chimneys you implant, we additionally oversize by 3 millimeters per chimney.
Frank, very nice. So you're highlighting the importance of oversizing. As you said, 30 degrees should be the oversized aortic stent graft. But sometimes we have more than one involved target vessels. So from the anatomy, from the morphological point of view, we should deploy more than one chimney grafts. And now is the question if we would expect more events, more issues, if we perform multiple chimneys versus single chimneys. Could you provide some information, Dr. Taneva, in this topic?
Exactly. We recently evaluated this performance, the performance of triple chimney within the Pericles registry. And we have some very promising results. The paper is upcoming very soon. And it seems like patency is quite good, but of course, they're not the results of single or double chimney nowadays.
So this analysis confirmed that the more chimneys we are doing, the higher the risk of complications, of events, of type 1A endoleaks.
And slightly worse the results, exactly.
And I think this is a very clear message, dear Frank, because there is no doubt that the using off-the-shelf devices give us the possibility to do it the same day, but we have to be very careful if we deploy several chimney grafts because, as we have seen, the risk is higher of having events. From the sizing and planning point of view, do you have some recommendations as anatomical constraints to avoid to perform chimneys?
Well, based on what you say, and I totally agree, we are doing, let's say, on an elective basis up to 2 chimneys. 3 chimneys we would only do, let's say, in the real urgent or bailout situations. So there are some anatomic constraints for doing chimneys indeed. First of all, in view of what I just said, when the superior mesenteric artery is about at the same level of the both renal arteries, this is a problem. Of course, the chimneys have to be implanted from above. So if there are access problems in the arm or whatever, then although it is rare, but it does occur, sometimes it's impossible to perform this technique also.
So you highlight the importance of evaluating the access from above before we plan chimneys. So in case of soft plaque,
like it's important to
shaky aorta, should...
Like it's important to evaluate the aorta when you come from below also in simple EVAR procedures.
Yes. Dr. Taneva, another question, and I think very often we heard from colleagues, they performing CT scan evaluation, and they think that we have a persistent gutter-related type 1A endoleak. So what should be the recommendation? How can we overcome this issue?
Well, there are several issues about the gutters. And at first, we should know that in the first CTA, if you perform it 1-2 days after the procedure, maybe there's still impairment of the blood, and you can still see some type 1A endoleaks. So patients wait, and let's see the next control CTA probably 1 month after the procedure. And then recommendation for oversizing. Always look for 30% oversizing in order to wrap around the chimney stents and achieve at least 15 millimeters of sealing zone at the neck. But sometimes it's not possible due to the diameter of the patient and due to the stented vessels. So we can't achieve this type of sealing. That's why sometimes we can see these gutter issues. In order to solve the gutters issues, if you have a persistent type 1A endoleak, we recommend to extend proximally if needed, and otherwise embolize, probably using onyx. That's our experience.
Mm-hmm. Very nice. In this context, I have to highlight the ongoing prospective multi-center trial Ghent, evaluating the performance of Chimney-EVAR in almost 20 centers. Professor Torsello is the principal investigator of this trial, and I'm very, very optimistic that we will have a very, very important new data very soon, because it's very important to see from this point of view how often we observed type 1A endoleaks at the completion angiography and what happened. And our experience showed that in the majority of the cases, they're disappearing. Yeah. So thank you, Professor Vermassen, Dr. Taneva, for the feedback, for your opinion about this appealing approach. There is no doubt that we have to learn, we have to evaluate the limitations of the technique. We have to evaluate cases which we had a suboptimal result. And evaluating this, we can only provide better performance, better results. In this context, we highlighted the importance of the degree of oversizing of the aortic stent graft if you perform this technique. We saw indeed also in the Pericles registry analysis that low volume centers have the tendency to have a less oversizing compared to high volume centers. But this is important to highlight that from the design, from the philosophy of the technique, you have to have enough, as you highlighted, Dr. Taneva, material to wrap up the chimney grafts. Very important point. The second point is the creation of a sufficient new sealing zone. I would recommend personally 20 millimeters, because we know that we cannot be perfect during the deployment and you are going to lose a few millimeters. So therefore, it's better to go for at least 20 to have your 15 millimeter new sealing zone and length. In addition with this is very important the combination of the devices. So the combination of the Endurant with the Advanta showed that Endurant with a nitinol endoskeleton conforms very well with the proximal part, rigid part of the Advanta. So with this nice conformability, you have a lower risk, as we have seen in the in vitro tests, of persistent at least gutter endoleaks. There is no doubt that we are more than glad to hear the new evidence, the new findings from the Ghent trial. In this context, I would like to thank you again, and I wish you a nice stay in Barcelona during the CIRSE meeting. Thank you.
Thank you very much.
Thank you.